Okay, no disclosures. Okay, first I want to tell you that when we're talking about internal impingement, we're not talking about the usual impingement we're seeing in the office, which is, subacromial impingement. You're going to see that predominantly middle-aged people, subacromial space, and we're talking about, in that case, impingement between the bursal aspect of the anterior supraspinatus and the acromion. In these throwers, what we're talking about, and Brandon alluded to this earlier, it's contact between the undersurface of the rotator cuff and the posterior superior glenoid, and this occurs at the posterior aspect of the supraspinatus, okay, as opposed to your subacromial impingement. Here's a depiction of that. This is from article by Gilles Walsh, and he was really the one that first characterized this term. This was a paper in 1992, described 17 throwing athletes had posterior shoulder pain in kind of that late cocking position, and arthroscopically you could see evidence of impingement between the glenoid and the rotator cuff. So there's different theories about kind of what causes this, what makes it worse. Gilles Walsh felt that this simply was repetitive physiologic contact, and thought that perhaps decreased humeral retroversion could worsen that problem. Chris Jobe and their group out in California felt like if there was increased glenohumeral motion, specifically if there was kind of anterior laxity, that would worsen internal impingement. And then the third theory was Burkhardt and Morgan, and what they said is really the problem here is a posterior capsular contracture that alters glenohumeral mechanics. You get a posterior superior shift of the humeral head, and that worsens internal impingement. So we're going to talk a lot about rotator cuff problems, but what else do we see with internal impingement? You can actually see quite commonly this posterior impaction of the humeral head. This is a throwing athlete of mine, posterior pain with late cocking. And when I say erroneously, I'm not saying the radiologist is misreading these, but it looks like a Hill-Sachs lesion. And so a lot of times the reports come back as a Hill-Sachs lesion, but you talk to the player and they've never had an anterior dislocation. So this truly is impaction. They can get pain from this. And I think that the people that truly are getting pain from that impaction lesion, that's difficult to treat because, again, it's a repetitive problem. What do we also see with internal impingement? You see tearing of the rotator cuff. So again, this is going to occur at the posterior aspect supraspinatus, anterior aspect infraspinatus. Two mechanisms possibly at play here. One would be just mechanical, where you're going to get impingement and peeling of the rotator cuff from this repetitive throwing thing. Also possibly from repetitive strain on the cuff, that can create cuff tearing. And as Brandon talked about earlier, you get highest EMG activity of the posterior cuff in follow-through. Less commonly, we'll see tearing of the anterior supraspinatus. I do think this is more problematic when you see this in throwers. Why would you get tearing of the anterior supraspinatus? Probably from tissue failure, from repetitive strain and torsion. You get peak activity of the supra and late cocking when it eccentrically contracts. So how are we going to treat this? Fortunately, most of the cuff tears are partial thickness tears because we're going to talk about the fact that repairing rotator cuffs and throwers results are not good. I would encourage you to always attempt non-surgical treatment first. You really may be surprised how well it works. This image you see right here is a player we signed with the Rockies who never had any shoulder pain. This was just a pre-signing shoulder MRI, and he's got like a 90% undersurface cuff tear here. I mean, if this guy walked in your office as a regular patient, you'd be talking to him about surgery. He never had any shoulder pain with us and finished out his career without any shoulder problems. This is a study by Mahata and looked at almost 90 college baseball players. About half of them had articular-sided partial thickness cuff tears. However, there was no difference in shoulder pain and strength with these players compared with the players who had no rotator cuff tears. In terms of non-surgical treatment, we'll have a lot of talks looking at this from a surgeon standpoint. Certainly there's injections we can do. I really would argue, rehab is going to be the key. A lot of things to look at, but as was referenced earlier, scapular control is going to be critical because if your scapula is in the wrong position, that's going to really accentuate that internal impingement. Same thing with optimized pitching mechanics, because if your mechanics are not good, again, you're going to just continue to bang the back of your shoulder as you're throwing. In terms of surgical treatment, usually we're talking about debridement of these rotator cuff tears, certainly if the tears are shallow. I usually do look in the subacromial space. The cuff is almost always normal there, and you may consider a subacromial decompression. That's kind of a typical undersurface tear on that picture at the top, and at the bottom you can see we've cleaned that up and it had pretty minimal tendon involvement. I'm not a big fan of considering a posture repair in this population, and the reason is these usually are not simple peel back injuries. There's usually some tissue loss, and so if you're going to do a so-called posture repair, you're going to have to pull that. You're going to have to pull that tendon lateral, and it's I think number one, it's probably going to fail. Number two, you could over tighten the shoulder, which is a huge problem with the thrower. You may consider repairing if there's delamination. So if you've got like a split between the deep and superficial layers of the cuff, these are actually some slides from Chris Ahmad, and basically you can see what he did. He didn't completely pull that tendon all the way back to the bone, but he's simply kind of sewing those two layers together using a spinal needle and some sutures tied in the subacromial space. How do rotator cuff repairs do? I always like to quote Jim Andrews, who told me one time, he said, "I've had better results treating rotator cuff tears and throwers without surgery than with surgery." Here's a couple older studies. Taboni, 1986. These were mini open cuff repairs. You can see only 41% of throwing athletes returned to prior level of competition. Andrews' study in 2006, similarly bad results, 12 major league pitchers with mini open cuff repair, only one returned to play. Here's some newer data. It's not much better. This is Brandon Erickson looking at the Major League Baseball injury database. 21 players who underwent cuff repair, 33% returned to play, 14% at the same level or higher, so pretty dismal results. The ones with rotator cuff debridement didn't do great, but certainly did better with 50% return to play. Another newer study, this was a systematic review, and there was a subset of 4 studies here with 43 baseball and softball players. 80% return to play, but if you look at the same level of play, only 38%. So again, not great results. What else could we think about here? This is not a throwing patient of mine, but somebody who's got an undersurface cuff tear. You can see on the bursal side, that little blue there is a suture I put through there to mark where that tear is, and the bursal side looks okay. There is the option of putting these collagen patches on the rotator cuff, and that kind of thickens up the tendon. And there's even some thought that in thickening the tendon, you take strain off those undersurface fibers, and that those can heal. Results in kind of regular people with this procedure is quite good. I personally, though, have not done it on any throwing athletes. So in summary, outcomes of rotator cuff repair are not good. If you do have to do surgery, a less is more approach is definitely worth taking. And many athletes can do reasonably well with a non-surgical treatment approach. And I would definitely recommend exhausting this prior to considering surgery. One last case study I always show people. This was a player of ours, 26-year-old pitcher, has this crappy looking cuff, shoulder pain. The agent says, "Well, I need surgery." I'm looking at this thinking, what am I going to do? Thankfully, we talked this guy into rehab. We gave him a PRP injection. He basically rehabbed the whole rest of the season and played another 10 years without any shoulder problems. So thanks very much.